Concern Worldwide has been working in Sierra Leone since 1996, focusing on emergency response, rehabilitation, and more recently on an expanded portfolio of health, education, and food in common markets, integrating considerations for gender, equality, prevention of gender-based violence, social protection, disaster risk reduction, HIV, and AIDS. In Sierra Leone, program implementation is concentrated in Tonkolili, Botloko, Western Area Urban, and Western Area Rural districts. The malaria disease burden. Malaria remains a worrisome cause of illness, death, and public spending in Sierra Leone. Women and children are disproportionately affected by the illness, and their economic realities are worsened by its effects. Behavior and practices remain still suboptimal at community level, where the use of insecticide-treated bed nets are not enforced, and health-seeking behaviors are neither prompt nor effective, contributing significantly to mortality. At the start of the project, the baseline study revealed that only 54% of children were treated within 24 hours after the onset of a fever, and only 57% of women with children 0 to 23 months took correct intermittent preventive treatment while pregnant with their last child. Health-seeking behavior was generally poor, but even more problematic was the shortage of testing and treatment commodities in PHUs, where government has declared that malaria is free of cost. Addressing malaria-related mortality and mobility became critical. The project: Treat and Prevent Malaria. Concern Worldwide was funded by Comic Relief at over £768,000 to implement the program for 3 years from October 2017 in Tonkolili district in 25 communities. A cost extension was granted to allow the project continue until March 2021.
National Health Coordinator for Concern Worldwide. My role with Track Malaria is it's one of the projects within the health sector for Concern in Sierra Leone. So I have overall technical and financial oversight for the project and support the implementation team, including the project manager, to implement the project. So the Track Malaria project was designed with the government of Sierra Leone in consultation. Malaria was obviously a global priority at that point for Comic Relief, but also a national priority for the Ministry of Health and Sanitation, especially with regards to children under 5 and pregnant women. The reason the project was operating in Tonkolili is it was one of the highest burden districts at the time of the design of the project, as well as being our base of operations. And the chiefdoms that were chosen, they were chosen by Ministry of Health through the DHMT because they were the highest burden chiefdoms within Tonkolili. So they were adding that to their strategic objectives when we started the project.
The project sought to address quality of care issues, contributing to the poor utilization of malaria-related health services by pregnant women and children under 5 who are especially vulnerable for increased risk of stillbirth, spontaneous abortion, maternal and fetal anemia, and neonatal deaths. Globally, children under the age of 5 account for 67% of all malaria deaths in 2018. Tap Malaria project activities. Tap Malaria was implemented in Tonkolili with the aim, in collaboration with traditional healers and influential women, of decreasing inappropriate testing and treatment by increasing access to and uptake of formal health services. This means that traditional healers and influential women acted as referral agents, as well as information disseminators to address myths and concerns that may prevent community members from accessing health services. In addition to this, Tap Malaria supported 25 facility management committees to improve the quality of care provided through improved monitoring, to hold facilities accountable for the services provided to the community. Concern worked with implementing partner CIDA, Community Integrated Development Association, who trained and supported the FMCs to hold bi-monthly meetings focused on monitoring the quality of care provided at their PHUs. The Tonkolele DHMT is Concern's primary collaborative partner on this project because they oversee the PHUs that the project supports. The TAP project built capacity at FMC level to analyze available data for decision-making on improving health outcomes, particularly in relation to malaria within their communities. The TAP project scope evolved substantially over the course of the 3.5 years, and there appeared a greater focus on women's empowerment through the role of the influential women, with the traditional healer and influential women role expanding beyond referrals into dispelling myths and facilitating community health talks, supporting PHO staff to distribute bed nets, and active searching for malaria cases in their communities. Fieldwork. Fieldwork was carried out in 4 FMCs, 4 PHUs, and 4 beneficiary communities. There were 4 influential women focus groups and key interviews with in-charges, traditional chiefs, and chairs of FMCs. The evaluation methodology. In addition to a systematic literature review and inception meetings, the project utilized qualitative methods, focus group discussions, key interviews, case studies, and a most significant change tool. The scoring criteria used the OECD DSC scoring criteria on a scale of 0 to 4, 0 being totally unacceptable performance and 4 being outstanding performance. We analyzed primary and secondary data of outcome indicators, as well as qualitative transcripts using open theme coding. We also analyzed and triangulated secondary quantitative data with qualitative data including the test review, semi-structured interviews, and case studies. The surge model. TAP Malaria adopted the surge model in 10 communities to help the communities set realistic threshold levels and appropriate trigger interventions at pre-identified levels to prepare the PHU and the community to manage a surge in cases. This was an innovation which enabled the health system to predict and cope with surges in malaria cases through the setting of caseload thresholds and a set of phased actions to respond flexibly to a threshold being met. The model had different stages: the emergency phase, the serious phase, and the normal phase or initial phase, all established based on the caseload. Key findings. The contribution of TAP Malaria to a reduction in mortality over the lifetime of the project is very significant, as was the increase in better healthcare seeking rate behavior at primary level in the beneficiary communities. Sustainability remains a major issue, but significant behavior change at community level means increasing attendance at healthcare facilities will continue, and fewer people will revert to traditional healers. At the initial stage, the design was innovative and unique. Both the Ministry of Health and the NMCP had reservations about working with influential women and traditional healers, seeing their roles as fringe and maybe even illegal. The project sought to use non-traditional means to effect behavior change. The overall aim to reduce malaria prevalence was on top of the priority list of the ministry, and so the design eventually won alignment with the Ministry of Health as well as the NMCP. The project was well aligned with the NMCP and MOH's priorities as outlined in the National Malaria Strategy. Concern also wanted to work through influential women, and the project was thus expanded to include them. As a result of the TAP project, the community structures were strengthened. New systems came into existence, and capacity was developed at village, facility, and personal levels. The growing interest of the FMC saw them going beyond their initial role to conduct active searches and monitor health facility attendance. The impact which the FMC has had in these communities might make this a valuable tool in the malaria management toolkit in West Africa, and indeed in the SPCC influence governing other diseases. In terms of scale-up, it is doubtful if the government has the resources to scale up the project in the same way that Concern has implemented it. However, some of the practices are easily replicated. Traditional healers and influential women want to be recognized. It is important they're treated with respect and not as outlaws or criminals. They should be incorporated as part of the solution because they have a lot of good advice to give. The most significant change. We collected responses from survey respondents on what was the most significant change they had seen during the lifetime of the project. The top issues that came up were the awareness that malaria treatment is free. More than 90% of respondents know that they have a right to free malaria treatment at any public health facility. The cost implications were previously a disincentive to using the health facility, as traditional healers were considered to be a cheaper source of health care. Now, community members understand that the cost of malpractice on their health can be high. A respondent who lost her infant child agreed that it would have been cheaper to have gone to the health facilities, even if she had had to pay. The knowledge that traditional herbs cannot cure malaria was also a significant change. This knowledge was complemented by the fact that the cure for malaria is medical. TAP Malaria Project, value for money. TAP Malaria results against the investment available demonstrated good value for money. The project met its objectives on increasing the uptake of preventive measures and appropriate health care seeking by pregnant women and caregivers. The target population is most vulnerable for illness, especially malaria, and they traditionally did not approach the health facility for treatment in the past. TAP Malaria has ensured the involvement of the community in increasing the uptake of preventive measures and appropriate health-seeking care by these groups. It also met its objectives on improving health service delivery at PHU to treat malaria and other diseases, including during surges of disease. Conclusions. On the overall evaluation criteria, the TAP Malaria project is rated 3. Performance in line with what would be expected of a well-functioning organization. It responded fully to the government and Tankolili's district felt needs. It used existing structures within the community, making it more likely that it will continue even when concern leaves. The project largely achieved its objectives, but not without its share of challenges. These include sometimes inadequate support of stakeholders in enforcing bylaws governing preventive behavior, including the use of bed nets and the cleaning of the environment. The workload for the traditional healers and the influential women can be a challenge with one traditional healer or influential women covering 5 or 6 villages to conduct sensitizations and referrals. The project responded fully to the felt needs and used existing structures. Project staff, however, felt that the entry and exit strategy was poor, with no formal launch of the project and inadequate publicity. In terms of effectiveness, the objectives were important to the ultimate aim of saving lives, improving the quality of care. As the capacity building support improved the knowledge of beneficiaries, they learned new skills. In terms of impact, the project had key social effects on the participants, improving cohesion and communication among different stakeholders within the healthcare system. The project was staffed mostly by national staff, enhancing local ownership of knowledge. Main recommendations. Project staff believe there should be a formal introduction of the traditional healer and influential women in selected communities to engage stakeholders. There needs to be an increase in the number of traditional healers and influential women to all catchment communities for better coverage whenever the opportunity arises. The surge models should place more emphasis on early warning systems that predict a spike before it occurs. The participatory community-centered approach is a good pilot to expand, supported by a livelihoods component that can compensate for the lack of incentive payments. The FMC intervention should extend to monitoring of prescription standards and timely reporting to prevent drug stockouts. The healthcare interventions are better off backed by social and behavior change components to strengthen prevention efforts. System strengthening is also needed for stock and inventory management support. Income generation should be promoted for participants through small business schemes, including solar electrification schemes and microfinance schemes. The aspects of the project which must easily transition to an extension is a deliberate focus on enough time to implement and cause behavior change, which is a slow process. A greater focus on beneficiary training, including healthcare workers and community health workers, and a greater emphasis on community involvement and engagement, including close collaboration with the DHMT, the NMCP, and the Ministry of Health.